a Wikividi documentaries production. Don't forget to like and subscribe. Enjoy. Infective endocarditis. Infective endocarditis is an infection of the inner surface of the heart, usually the valves. Symptoms may include fever, small areas of bleeding into the skin, heart murmur, feeling tired, and low red blood cell count. Complications may include valvular insufficiency, heart failure, stroke, and kidney failure. The cause is typically a bacterial infection and less commonly a fungal infection. Risk factors include valvular heart disease, including rheumatic disease, congenital heart disease, artificial valves, hemodialysis, intravenous drug use, and electronic pacemakers. The bacteria most commonly involved are Streptococci or Staphylococci. Diagnosis is suspected based on symptoms and supported by blood cultures or ultrasound. There is also a non-infective form of endocarditis. The usefulness of antibiotics following dental procedures for prevention is unclear. Some recommend them in those at high risk. Treatment is generally with intravenous antibiotics. The choice of antibiotics is based on results of blood cultures. Occasionally heart surgery is required. The number of people affected is about 5 per 100,000 per year. Rates, however, vary between regions of the world. Males are affected more often than females. The risk of death among those infected is about 25%. Without treatment it is almost universally fatal. Cause. Many microorganisms can cause infective endocarditis. These are generally isolated by blood culture, where the patient's blood is drawn, and any growth is noted and identified. The term bacterial endocarditis commonly is used, reflecting the fact that most cases of EA are due to bacteria. However, infective endocarditis has become the preferred term. Bacterial. Staphylococcus aureus followed by Streptococci of the viridans group, and coagulase-negative Staphylococci are the three most common organisms responsible for infective endocarditis. Other Streptococci and Enterococci are also a frequent cause of infective endocarditis. Heart-check group of microorganisms and fungi are seen less frequently in North America. The viridians group include S. oralis, S. mitis, S. sanguis, S. gordonii and S. parasanguis. The primary habitats for these organisms are oral cavity and upper respiratory tract. These bacteria are present in the normal oral flora and enter the bloodstream usually by dental surgical procedures. As such, dental surgeons must fully carry out protective and preventive measures. In some countries like the USA, higher-risk patients may be given prophylactic antibiotics such as penicillin or clindamycin for penicillin-allergic patients prior to dental procedures. Prophylactics should be bactericidal rather than bacteriostatic. Such measures are not taken in certain countries like Scotland due to the fear of antibiotic resistance. As bacteria is the most common cause of infective endocarditis, antibiotics such as penicillin and amoxicillin are used in prophylaxis. Microbiological culture could also be used to identify the infecting organism and testing its sensitivity to different types of antibiotics. Viridans alpha hemolytic Streptococci, that are present in the mouth, are the most frequently isolated microorganisms when the infection is acquired in a community setting. In contrast, Staphylococcus bloodstream infections are frequently acquired in a healthcare setting, where they can enter the bloodstream through procedures that cause break in the integrity of skin, such as surgery, catheterization, or during access of long-term indwelling catheters or secondary to intravenous injection of recreational drugs. Enterococcus can enter the bloodstream as a consequence of abnormalities in the gastrointestinal or genitourinary tracts. Some organisms, when isolated, give valuable clues to the cause, as they tend to be specific. Multiple case reports of infective endocarditis caused by unusual organisms have been published. Propionibacterium sp. which are normal skin flora, have been responsible for infective endocarditis, sometimes leading to deaths due to the indolent course of this abscess-producing infection. Tropharema whipplei has caused endocarditis without gastrointestinal involvement. Citrobacter kozeri was found in an immunocompetent adult. Neisseria bacilliformis was found in a patient with a bicuspid aortic valve. Fungal endocarditis is a fatal and one of the most serious forms of infective endocarditis. The types of fungi most seen associated with this disease are: Candida albicans is found as a spherical or oval budding yeast. It is associated with endocarditis in 4 drug users, patients with prosthetic valves, and immunocompromised patients. It forms biofilms around thick-walled resting structures like prosthetic heart valves and additionally colonizes and penetrates endothelial walls. C. albicans is responsible for 24–46% of all the cases of FA, and its mortality rate is an astonishing 46.6–50%. Other fungi demonstrated to cause endocarditis are Histoplasma capsulatum and Aspergillus. Aspergillus contributes to roughly 25% of FA cases. Endocarditis with Trichosporon asahi has also been reported in a case report. Risk factors. Risk factors for infective endocarditis are based on the premise that in a healthy individual, bacteremia is cleared quickly, with no adverse consequences. However, if a heart valve is damaged, the bacteria can attach themselves to the valve, resulting in infective endocarditis. Additionally, in individuals with weakened immune systems, the concentration of bacteria in the blood can reach levels high enough to increase the probability that some will attach to the valve. Some significant risk factors are listed here. More detailed descriptions of these and other risk factors are provided below. Other conditions that result in large numbers of bacteria entering into the bloodstream include colorectal cancer, serious urinary tract infections, and drug injection. With a large number of bacteria, even a normal heart valve may become infected. A more virulent organism can cause infective endocarditis by infecting even a normal heart valve. Intravenous drug users tend to get their right-sided heart valves infected because the veins that are injected drain into the right side of the heart. In rheumatic heart disease, infection occurs on the aortic and the mitral valves on the left side of the heart. Other factors that increase the risk of developing infective endocarditis are low levels of white blood cells, immunodeficiency or immunosuppression, malignancy, diabetes mellitus, and alcohol abuse. Dental operations. In the past, 1 in 8 cases of infective endocarditis were because of bacteremia caused by dental procedures, such as a cleaning or extraction of a tooth. This was thought to be more clinically significant than it actually was. However, it is important that a dentist or a dental hygienist be told of any heart problems before commencing treatment. Antibiotics are administered to patients with certain heart conditions as a precaution, although this practice has changed in the US, with new American Heart Association guidelines released in 2007, and in the UK as of March 2008 due to new NICE guidelines. Everyday toothbrushing and flossing will similarly cause bacteremia, so a high standard of oral health should be adhered to at all times. Although there is little evidence to support antibiotic prophylaxis for dental treatment, the current American Heart Association guidelines are highly accepted by clinicians and patients. Pathogenesis. Damaged valves and endocardium contribute to the development of infective endocarditis. Specifically, the damaged part of a heart valve forms a local blood clot, a condition known as non-bacterial thrombotic endocarditis. The platelet and fibrin deposits that form as part of the blood clotting process allow bacteria to take hold and form vegetations. As previously mentioned, the body has no direct methods of combating valvular vegetations, because the valves do not have a dedicated blood supply. This combination of damaged valves, bacterial growth, and lack of a strong immune response results in infective endocarditis. Damage to the valves and endocardium can be caused by. The risk factors for infective endocarditis provide a more extensive list of conditions that can damage the heart. Diagnosis. In general, the Duke criteria should be fulfilled in order to establish the diagnosis of endocarditis. The blood tests C-reactive protein and procalcitonin have not been found to be particularly useful in helping make or rule out the diagnosis. As the Duke criteria rely heavily on the results of echocardiography, research is addressed when to order an echocardiogram by using signs and symptoms to predict occult endocarditis among patients with intravenous drug abuse and among non-drug abusing patients. Unfortunately, this research is over 20 years old, and it is possible that changes in the epidemiology of endocarditis and bacteria such as Staphylococcus make the following estimates incorrect. Ultrasound. The transthoracic echocardiogram has a sensitivity and specificity of approximately 65%, and 95% if the echocardiographer believes there is probable or almost certain evidence of endocarditis. Modified Duke criteria. Established in 1994 by the Duke Endocarditis Service and revised in 2000, the Duke criteria are a collection of major and minor criteria used to establish a diagnosis of infective endocarditis. According to the Duke criteria, diagnosis of infective endocarditis can be definite, possible, or rejected. A diagnosis of infective endocarditis is definite if either the following pathological or clinical criteria are met. Diagnosis of infective endocarditis is possible if one of the following combinations of clinical criteria are met. Risk. Among people who do not choose intravenous drugs and have a fever in the emergency room, there is a less than 5% chance of occult endocarditis. Mallows in 1987 found no cases of endocarditis nor of staphylococcal bacteremia among 135 febrile patients in the emergency room. The upper confidence interval for 0% of 135 is 5%, so for statistical reasons alone, there is up to a 5% chance of endocarditis among these patients. In contrast, Libovici found that among 113 non-selected adults admitted to the hospital because of fever, there were 2 cases of endocarditis. Among people who do use intravenous drugs and have a fever in the emergency room, there is about a 10% to 15% prevalence of endocarditis. This estimate is not substantially changed by whether the doctor believes the patient has a trivial explanation for their fever. Weiser found that 13% of 121 patients had endocarditis. Marantz also found a prevalence of endocarditis of 13% among such patients in the emergency room with fever. Summit found a 6% incidence among 283 such patients, but after excluding patients with initially apparent major illness to explain the fever, there was a 7% prevalence of endocarditis. Among people with staphylococcal bacteremia, one study found a 29% prevalence of endocarditis in community-acquired SAB versus 5% in nosocomial SAB. However, only 2% of strains were resistant to methicillin, and so these numbers may be low in areas of higher resistance. Brought to you by Wikividi Documentaries. Would you like to know more?